أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Now, my dear students of final year Mbbs, including the third year Mbbs and the postgraduates who are interested to attend this session, that about something about the hematuria with anasaka and hypertension for the final year. It is a specific tutorial for the final year Mbbs, and the postgraduates can be benefited if they want to listen. Now, we have been discussing previously about the outcomes of the renal decompensation. Kidneys are one of the organs which are decompensated. If they are decompensated, the negative feedback mechanisms are very effective for them, and compensation soon occurs in most of the cases. And the kidneys are the essential organs for the life, one of the essential organs for the life. Now, I have seen one case which I want to discuss, and that is a case of a 14 years old boy of a class 7th student or 8th. Now, he was presented to me with the past history of cellulitis of the leg, and he was treated for it. After 20 days or 15 days after it, he developed headache, anorexia, and periorbital puffiness, followed by the swollen limbs. On examination at the home, it was done, the temperature was taken as 101 degree Fahrenheit. When he arrived in the medical emergency, that the temperature is rising, and he also noted at this time the brown colored urination. In the medical emergency, the blood pressure was noted 170 by 110, boy of 10 years of age. And there was a periorbital limb and lower limb edema, meaning the whole body was involved. He was slightly short of breath because the respiratory rate was 24 per minute. The other findings which we have found it during the examination, that there is a scar formation in the part of the lower limb, which he said that he was treated for infection of the leg. And we asked for the drugs he was put on, and they said that it was probably the lincomycins was injected, and the analgesics like the paracetamol was given, and the local dressings were applied. So we investigated. Because of the hypertension, the blood CBC, the hemoglobin was found to be 13.5 gram. Total leukocyte count was 14,200, and it was neutrophil leukocytosis. The CRP was 25, normal was up to 5. The X-ray test was done it was blunting of the right costophrenic angle. Otherwise, the lung fields were clear. Urine RE examination, the specific variety was 1.025. The pH is 5.8. Still acidic pH is there. Odor was, it is a nitrogenous type of a smell coming out. And the color of the urine was dark brown color. And on the biochemically, he was tested for the glucose which was nil, protein was +1, and then the pH, I've already said about the pH, it was 5.7 or 5.8. It is acidic urine, no problem. And the bilirubin and urobilinogen was normal at the time of the examination, and the blood was positive, +3 positive. On the microscopy, WBC was 7 per high power field. Nitrite was negative, and the RBC were numerous per high power field. The crystals as well as the sediments, they are not seen. Bacteria are very few, were very few at that time. This was the case which I have seen. And we have investigated further for this. And we found that he had the hypertension which was usually resistant to the commonly used antihypertensives. Monotherapy was given with furosemide, although, but he was not responded well. The other, the liver function tests, the serum creatinine was 1.2 and the blood urea was 65. The 24-hour protein was present 1.7 gram per liter. So there was proteinuria of sub-nephrotic level. I already said about it. What do you mean by proteinuria? In my previous lecture, if you have listened it. So there was the hard data was that he was a young boy, was treated for some skin infection. He developed the anasarca and hypertension and hematuria. So we labeled this patient after the protein, after 24-hour urinary protein of subnephrotic level, that he was probably should be labeled as nephritic syndrome. Now, nephritic syndrome this terminology was not used when I was in the final year MBBS. When I was doing the fellowship examination, then this terminology was known to me. In the 1982, up till 1980, 81, 82, up to that which I have cleared in final year MBBS in 1982. 1982. So before it, the terminology was not used. It was called as a nephrotic minus plus syndrome, something like this. These terminologies were used. Now, this is the specific type of a disorder which is called nephritic syndrome. Now, this is the structure of the kidneys, just for revision for you. The blood supply is coming from the renal arteries. Drainage was in your veins, bilateral kidneys, and there is a functional unit of the kidney was nephron, where is the Bowman's capsule and glomerulus, and then space, and then coming to the convoluted tubules, proximal loop of Henle, distal convoluted tubules, collecting ducts, and forming the pyramids and the papilla, drilling into the calculi, minor calculi or major calculi, calyx of the minor calyces, and into the renal pelvis and then ureter. Now, based on this structure of the kidneys, the renal parenchyma, renal medulla, and cortex is there, and on histology is concerned. I have already talked about it, the different diseases affecting the kidneys, acute renal failure, whether it was pre-renal or renal or post-renal, chronic renal failure, or uremia, which I have discussed previously. And then I have discussed the nephrotic syndrome. And now this is, which we labeled as nephritic syndrome, is a syndrome comprising the signs of nephritis, inflammation of the nephron, which is a kidney disease involving the inflammation. It often occurs in the glomerulus. When it is involved in the glomerulus, it is called glomerulonephritis. If there is inflammation of the glomeruli, it is characterized by the inflammation and the thinning of the glomerular basement membrane and occurrence of the small pores in the porocytes of the glomerulus, that is capillaries. These pores become larger and larger enough to permit both the proteins and RBC, which is 7.2 micron, a diameter of 7.2 micron, even they pass through these pores into the urine, and resulting in the proteinuria and hematuria. And kidney responded because of the inflammation, because of the high inflammation going on in the glomerulus, reflected back in the increase in the blood pressure, and that is hypertension. Presentation, actually, the signs and symptoms are consistent with the nephritic syndrome, include essential of diagnosis. The hematuria, red blood cells in the urine, proteinuria, protein in the urine, ranging from subnephrotic level. It should be less than 3.5. In this patient, it was 1.6. Although it is rarely above nephrotic range, very rare. If it is there, it is called nephritic syndrome. If you have the evidence of oliguria plus hypertension plus hematuria plus heavy proteinuria plus hypertension, and this condition is known as nephritic syndrome. Hypertension resulting resting blood pressure is persistently above 138/80 because it is negative feedback mechanism, because of the caliber of the vessels are now small enough to create this hypertension. So it is more than which is required. It means that it is above normal. In this condition, it was 170/110. It is stage 2 hypertension in this condition, according to the new protocol diagnostic protocol given by the WHO. There will be blurred vision because of the hypertension and because of the involvement of the tunnel vessels. There will be erythemia biochemically, increased plasma urea and creatinine. Yes, it is higher on site. Oliguria, low urine output, it is less than 400 ml or 300 ml per day. Red blood casts seen with the urinalysis and microscopy. Pyuria may be seen in white blood cells of person. It may be possible. It is not the essential of the diagnosis. Etiology, we will divide into, if you want to understand very clear concept, of this disease, you have to divide into three. The post-streptococcal glomerulonephritis, IgA nephropathy, which is called Berger's disease, and rapidly and progressive glomerulonephritis. These three conditions, main conditions, are there for the etiology of nephritic syndrome. All three conditions are associated with the autoimmune reactions, that the antigen-antibody complex are formed, or the antibodies are acting directly on the nephron and causing the injury, directly or indirectly. The first one is the post-streptococcal glomerulonephritis. It is very similar to the IgA nephropathy, and it is also called the proliferative type of the glomerulonephritis. It usually occurs in children who have recently had an upper respiratory infection. Here it is not a respiratory infection, but a skin infection. Now it is associated with actually some of the serotypes, specifically speaking, which are not associated with the, or not similar as the streptococcal infection causing the rheumatic fever. It is these serotypes for the rheumatic fever are different than the proliferative glomerulonephritis. They cause actually in this condition the autoimmune reaction. But in contrast with the IgA nephropathy, however, this condition typically present in 2 to 3 weeks after recovering from here it is recovering from the streptococcal cellulitis by the streptococcus bacteria. The symptoms at onset are very similar to the same, because in both conditions the targeted people are teenagers or small children, including abdominal pain and hematuria, edema, and oliguria. These are essential of diagnosis: oliguria, edema, hematuria. But in IgA nephropathy, which is also called the Berger's disease, it is seen mostly in the children. Again, now it is seen in some of the viral infection may be involved, or maybe the respiratory tract infection for the streptococcal serotypes, specific serotypes are involved. Symptoms typically present in Berger's disease within 1 to 2 weeks of this non-specific urinary tract infection, upper respiratory tract infection, with severe frank abdominal pain and the gross hematuria characterized by the dark brown urine or red colored urine, and edema of the hands and the feet and the face. Both conditions are associated with hypertension in most of the cases. The third condition is an interesting situation. It is called the rapidly and progressive glomerulonephritis. It is classified according to the American College of Nephrology and supported by WHO into 3, type 1, type 2, and type 3, and this classification depends upon the immunofluorescence patterns. Now, type 1 is accounting for the approximately 20% of the rapidly and progressive glomerulonephritis. It is also called the anti-glomerulobasement membrane glomerulonephritis, and it is characterized by the presence of the autoantibodies directed against the type 4 collagen, specifically the non-collagenous region of its alpha chain in the glomerular basement membrane. But some cases are associated with the antibodies directed against the basement membrane of the lung also, and that is producing the Goodpasture syndrome. It is called the renopulmonary syndromes. And both the kidneys and lungs are involved. One is classical example is Goodpasture syndrome. Other conditions may be also cause this renal or renopulmonary type of the syndromes, like tuberculosis, for example, like for example the leukocytosis, like for example the microangiitis, polyangiitis with nephropathy, that is what we call as vaginal scleromatosis, and there are other conditions as well which can cause the renal-pulmonary involvement at the same time. This is the Goodpasture syndrome. The majority of the Goodpasture syndrome, however, features anti-IgM antibodies alone. If they are present, that's all right. If they are not present, it should be considered idiopathic. If the other conditions are ruled out, which I have already said, that is a renal-pulmonary type of involvement. Type 2 is characterized by the deposition of immune complexes in the glomerular tissues. It causes 25% of all cases of the rapidly and progressive nephritis. Any immune complex diseases, which including the systemic erythematosus, Henoch papra, and including the IgA nephropathy even, and some other autoimmune diseases can cause it. And that involves the glomerulus, and it may progress to the rapidly and progressive glomerulonephritis if severe enough. But typically, actually, it is present in SLE. You can remember SLE is lies in type 2. Type 3, also known as POSI, immune rapidly and progressive glomerulonephritis, account for about 55% of all cases of RPGN, and features neither the immune complex are seen nor anti-GM antibodies were present, and instead the glomeruli damaged in an undefined manner, which is idiopathic. We don't know exactly, perhaps through the activation of the neutrophils in response to the P-ANCA, the anti-neutrophilic cytoplasmic antibody, probably. Type 3 RPGN may be isolated to the glomerulus, primary or idiopathic, or associated with systemic diseases secondary. In most cases of the rate, that is, systemic diseases, the ANCA-associated vasculitis, like, for example, the polyarteritis nodosa, and the glomerulonephritis with polyangiitis, that is vaginal syndrome, or microscopic polyangiitis, or it may be associated with the glomerulonephritis with the polyangiitis, that is the what we call as the Chug and Strauss syndrome. So these diseases are vasculitic type of disease that may be associated. It may be other than that. It may be giant cell arteritis. It may be other diseases which are causing the vasculitis. If they cause these nephritic syndrome, probably it is the rapidly and progressive glomerulonephritis. So it is type 1 RPGN or type 2 RPGN, or it is type 3 rapidly and progressive glomerulonephritis. Now, diagnosis based upon the history and then examination. Serum analysis often aids in the diagnosis of the specific underlying disease. The presence of the anti-glomerulus antibodies suggest of the type 1 rapidly and progressive glomerulonephritis of anti-nuclear antibodies may support a diagnosis of SLE. Type 2 and type 3 may be associated with the ANCA positive serum. In this fashion, it can be diagnosed, it may be RPGN1 or RPGN type 2 or RPGN type 3. The impaired function in an individual who had the condition for the fewer than 3 months is characterized by the RPGN. So it is a progressive disease. An ultrasonographic examination of the abdomen should be obtained, although the presence of the sediment in the urine on examination can indicate the proliferative glomerulonephritis, but if not diagnostic. Many cases of the RBC cast or something like this may be seen in this. but it is not diagnostic. Many cases of the rapidly and progressive glomerulonephritis, it will definitely need the renal biopsy to make a diagnosis and the outcomes of the disease. Sure about it. This is a renal biopsy you see here. The glomerulus is encircled by the acute inflammatory cells. It is diagnostic. The disease causing de-repetitive glomerulonephritis diagnosis, 100% gold standard, actually is the renal biopsy. Whether it is seen as RPGN, the destruction, and the specific parameters, histological parameters. Management, of course, of the autoimmune diseases. All are autoimmune diseases. Therapy consists of the combination of the rituximab or it may be added with the corticosteroids or with immunosuppressive agent like cyclophosphamide. With the substitution afterwards with azathioprine for cyclophosphamide, because cyclophosphamide is difficult to handle because it can cause the hemorrhagic cystitis and many people cannot tolerate the cyclophosphamide. If it is not, you can replace with the cyclophosphamide, replace with the azathioprine. So it's a combination of monoclonal antibodies, rituximab with steroids plus azathioprine in most of the cases. Cyclosporine can be given if the condition is not responding. When remission is achieved, the immunosuppressants are still used for a prolonged period of time. Usually steroids with the azathioprine oblique rituximab infusions, say it is 6 months or over than that. It should be continued until all renal function are normalized and the rebiopsy showed normal nephrons now. It should be continued. So this is what is called the nephritic syndrome. I hope that you have understood the difference between the nephrotic syndrome and nephritic syndrome. Both conditions should justify the essentials of diagnosis for the nephrotic, for the nephritic. I hope that this part of, there are few important chapters which I have covered in nephrology. Because of the lack of the time and the people are appearing in the examinations, I will then continue afterwards with the gastroenterology and hepatology, followed by the rheumatology and neurology. If time allow me, I will go for the hematology and infectious diseases, etc. In this fashion, all of the medicine, most of the medicine, internal medicine will be covered in the due time. I hope that you will follow these and give me the feedback on my WhatsApp number which I have given to you. And the group is MIPME, MIPME. Its WhatsApp number is 0336131196. You give them SMS and I will include in my group. Although these presentations are also uploaded in the YouTube channel. It's my own channel. Also, there is a web which I owned and I have sent it on the MIPME. I am actually under my website was under uploading process. Day by day I am uploading, and I hope that the knowledge will be gained or the final year, or the people who are appearing the foreign examinations, or those people who are doing the fellowships examinations or membership examination in Pakistan. I hope that you will be passed in the examination, inshallah ta'ala. Wish you good luck. Wama alayna illa al-balagh. Assalamu alaikum wa rahmatullahi wa barakatuh.